Welcome back to Open Heart Sport. Today I am going to discuss Internal Medicine 8.14 Appropriate Treatment Plan for Essential Hypertension. We have discussed the classification and investigations for hypertension earlier. So, it's a comprehensive approach should include the lifestyle, pharmacotherapy, and monitoring. These are three parts of the comprehensive plan. Lifestyle modification is the first line thing to be done for all patients. We should try to reduce the salt intake to less than 5 grams. Added salt should be avoided. And DASH diet is useful. Plenty of fruits. Limit alcohol, caffeine, and saturated fat. Then the BMI should be, ideally for Indians, it should be less than 23. At least it should be made less than 25 kilogram per meter square. Do exercise for 30 minutes a day, that is approximately 150 minutes per week, at least 5 days a week. Stop smoking, and appropriate stress management should also be done, yoga and other things. The pharmacological therapy, the definite indication when the BP is more than 140 over 90, 140, 90, you have to start treatment. If there are comorbidities, the treatment is 130, more than 130/80, that is stage 1 hypertension. We should treat if patient has comorbidities like diabetes, CKD, and coronary heart disease. One of the recommended medication is thiazide. Hydrochlorothiazide, you can give 12.5 to 25 milligrams daily. Chlorthalidone 12.5 to 25 milligram per day. Precautions are, one is it produces hypokalemia and hyponatremia, especially in the elderly. So be careful when you give thiazides. When the uric acid is high, hyperuricemia, again should be careful in giving thiazides. Then comes the AC inhibitor. AC usual drugs is enalapril, give 5 to 20 milligrams per day. Lisinopril 10 to 40 milligrams per day. And the precaution, one, you can produce hyperkalemia, check the potassium, and transient rise in creatinine can also occur. Up to 20% rise of creatinine, that is if a patient has got 1 creatinine at the beginning, up to 1.2 milligram, it is okay. More than that, you should discontinue. And it can produce troublesome hockey cough, and it is of course contraindicated in pregnancy. And it is mandatory to have a serum creatinine and potassium before starting treatment and after 1 week of treatment. That should be kept in mind. Why this produces rise in creatinine? Because as we know, the AC and ARB produce a vasodilation in the efferent arterioles. So what will happen when different arterioles are dilated and afferent is not dilated? So what will happen? The flow of blood through the glomerulus will be easy. That is the perfusion pressure decreased. So that is the reason for the change in the renal function. Then ARBs. There's a losartan 50 to 100 milligram per day, valsartan 80 to 160 milligram per day. Again, the same precaution, hyperkalemia and renal function monitoring should be done. Calcium channel blockers are one of the preferred drugs. The commonly used drug is amlodipine 5 to 10 milligrams. The maximum dose is 10 milligrams. Diltiazem can also be given 120 to 360 milligrams. 120 to 360. So usually this is given for angina and cardiac problems rather than as an antihypertensive. The calcium channel blocker, especially amlodipine, produces angle edema, can produce bradycardia, and verapamil can produce troublesome constipation. So these are the side effects of the calcium channel blockers. Then another drug is the nifedipine. Nifedipine, if you are giving, either give the controlled release form or at least the retard preparation should be given. The capsule form should not be given. Then the other drugs, beta blockers. Beta blockers are gradually being phased out from the treatment of hypertension unless there is a comorbidity like a coronary disease or arrhythmias. Then second is the other drug is a spironolactone in resistant hypertension, 25 to 50 milligram. But again, remember, can produce hyperkalemia. Already the patient may be on ACE and or ARP both, and addition of spironolactone can lead on to hyperkalemia. So BP should be checked every 1 to 3 months. The renal function, electrolytes, glucose, lipids should be monitored. Then what is the target? Target BP is less than 140/90 in protein, and it should be less than 130/80 in diabetes mellitus, CKD, and high risk groups. So remember this. So routinely you target for less than 140/90. Patient education is important. Many times what happens is patient is given drug for 1 month and then come after. They will be coming after 3 or 4 years with renal dysfunction, telling that they have been asked to take only for 1 month. So adherence to treatment, proper education, recognize the side effects, and long-term lifestyle commitment should be there. And nowadays, combination therapy is routinely given, especially when stage 2 hypertension with the BP 160/100, more than 160/100 millimeters of mercury. You start with the combination therapy initially. Or BP is more than 20 systolic or 10 diastolic above the target, you can start. High cardiovascular risk can start early or uncontrolled with the single drug. Preferred combinations are ACE or ARB plus calcium channel or diuretic. Never combine ACE plus ARB. It is absolutely combined. You cannot compare. So the preferred combination is ACE or ARB plus calcium channel blocker or a diuretic. So that is the preferred combination therapy. Then we should remember something regarding the compelling indications for treatment. That is, if a patient is diabetic, is done go for AC inhibitor or ARB because of the renal protection. In CKD, again AC inhibitor or ARB. Somebody with a coronary disease, post myocardial infarction, beta blockers can be given. If there is cardiac failure, you can give AC inhibitor, diuretics, beta blocker. Stroke prevention, thiazides and AC inhibitors. Alpha blockers are sometimes given, the example prazosin 1 to 5 milligrams per day, especially with the patient has got a BPH benign prostatic hypertrophy with hypertension. They are not first line treatment for hypertension. Can produce post hypertension and dizziness. So it's always better, or always make it a habit to make the standing blood pressure when somebody is on antihypertensive, especially alpha blockers. Then another drug is clonidine, especially patient with the CKD and BP is not getting control. You may start with the clonidine. Indapamide 1.25 to 2.5 milligram once daily is another drug. Better cardiovascular outcome, less metabolic side effects compared to hydrochlorothiazide. Electrolyte imbalance can occur, of course. Resistant hypertension, the confirm adherence, rule out secondary causes, add spironolactone, consider alpha beta blockers, and a specialist reference. I will be discussing about resistant hypertension in another session. So management requires lifestyle modification plus pharmacotherapy tailored to patient's profile. Hope this session is useful to you. Stay tuned for further videos. Thank you.